harmed from those. So we need to know a little bit more about who we're treating. So there are lots of potential actionable applications of hemodynamic information, and that's very important. It's all very well looking at hemodynamics and being a cardiologist, and we love hemodynamics, etc. But if they're just there on the mantelpiece and they're not actually useful for anything, then that's not much good, is it? But I think that there is actionable information that we can get for the management of heart failure in terms of medications and other interventions like cardiac resynchronization therapy. I think we could do a lot more with hemodynamic information for hypertension. We're perhaps a little bit more familiar with using hemodynamics in the acute cardiovascular setting, although much less common to see invasive measurements, at least in the cardiology wards or the coronary care unit rather than the intensive care unit. Increasingly, I think the hemodynamics is reserved for the intensive care unit, so with for the very sick patients. So we're losing out, I think, in the those who are in more intermediate stage. And of course, we might also use hemodynamic information for screening for cardiac dysfunction. I'm particularly interested in its potential for monitoring the effects of chemotherapy to make sure in the acute and chronic setting that the patients are appropriately managed. And also for potentially management of chronic kidney disease and hemodialysis. Now, we're not going to have time to talk about all of these in depth, but perhaps give you some flavor of what I think. So, first of all, I'll mention the most famous living cardiologist of them all, Professor Braunwald. And this is his definition of heart failure. And as you can see, it depends quite heavily on hemodynamic definition, both in terms of the pumping, the cardiac output, and the filling pressure. So he certainly thinks that hemodynamics are important, and I would agree with him. I think most of us would. So let's think about the clinical assessments of your patients. Now, it's fairly easy to measure heart rate and rhythm, although there are people who even think that we're not very good at diagnosing atrial fibrillation on a clinical examination. We're probably not that great at taking blood pressure. If you see so many clinics, the blood pressure will be rounded to the nearest 5 or 10, and I'm as guilty as the next person of doing that. And then we have the things that we work out mostly by guesswork. Cardiac outputs, you sort of take a look at the patient, you feel their toes, and you say, well, I think it might be up or it might be down. Vascular resistance, well, we sort of get some idea from the blood pressure and whether the patient's cold or warm. Filling pressure, really very difficult to know. We guess that if the patient's breathless, they might have high filling pressure. Obviously, if they've got gross edema, when it's gross, you can guess pretty accurately. Telling the nested or what the stage of cardiac dysfunction, they're all quite difficult. And obviously, some people are much better at guessing than others. Others have spent much more time training to get it right. So there'll be people who are mostly right, and then there'll be the rest of us who are in the dark most of the time. So what if we had an inexpensive, non-invasive, simple, reliable, real-time point-of-care method of assessing hemodynamics, so you don't have to wait for the results to come from another department? You can measure it on the patient there and then, and use it in your daily management. Well, a number of ways of measuring hemodynamics, and they fit these criteria to a greater or lesser extent. We've, of course, got Swan-Ganz catheters, but they're invasive and high cost. We've got the CardioMEMS system, even more expensive. It is invasive, although the procedure is relatively minor. But it doesn't actually give you continuous hemodynamic data. A patient's got to lie on that couch you can see in the middle of the screen here, perhaps. And so you only get intermittent hemodynamic data, and you very often can't get it at clinic. You have to have the pillow, you have to have the device which is linked to the patient, and the reader that's linked to the patient, which is at home. So you can't measure it at clinic. So it's a bit of a faff. Then there's photoplethysmography. That's you can see the person with the bandage on their finger. Well, that's a plethysmographic device that measures the expansion of the small arteries in the finger. And by a number of complex equations, they can get an idea of what your cardiac output might be from your finger pressures. A lot of debate about exactly how reliable that is. I've been quite impressed at times. But the kit, again, is quite expensive kit. Echocardiography certainly gets cheaper. It's continuous, and you need an experienced operator to really make it sing. Blood biomarkers, again, they're not continuous, and you can easily be paying 30 or 40 euros or dollars for a measurement of NT-proBNP, for instance. So over time, that can get quite expensive. And then we have hemodynamic bioimpedance, and that's been around for quite some time. You can see in the bottom right-hand corner, somebody with some electrodes on their chest. It used to be that thoracic bioimpedance was the thing. But the NICAS monitor uses a different system, and I'll hand over to the physicist to explain the differences between the limb and the thoracic bioimpedance. But with these just electrodes on the wrist, and they can be wrist to wrist or wrist to ankle, you can measure hemodynamics. There is another type of bioimpedance scales, which are also quite interesting, but of course they don't measure hemodynamics. So we have these various options, but are they actionable? So here I've got 4 patients, 2 with heart failure and 2 with hypertension, and I've given you the normal range for the hemodynamics. So let's see what the hemodynamic information would be for these 4 patients with rather, at least the patients with heart failure and patients with hypertension each have rather similar blood pressures. So here's the heart failure patient 1. You can see the cardiac index is normal, CVP borderline, and the systemic vascular resistance works out at the lower limit of normal. You wouldn't want to be aggressively vasodilating this patient. And in fact, if the patient was feeling well, you might be rather pleased that the patient was in a good hemodynamic situation. On the other hand, this patient with an identical blood pressure, you can see cardiac index a bit lower, CVP a little bit higher. This patient's vascular resistance is really quite high. This is a patient who does need more aggressive vasodilator therapy. They either need to make sure that they're on the target doses of ACE and ARNI, and NYHA class 3, you might think about some of the newer vasodilators like vericiguat. But this patient looks as though they need a little bit more. What about the patients with hypertension? Well, you can see that the first patient with hypertension has rather dynamic circulation and rather a normal vascular resistance. I'm not sure that you would want to vasodilate this patient further. You would be thinking about maybe a beta blocker or a thiazide or an MRA based on these hemodynamics. On the other hand, the second patient with hypertension, they have a high vascular resistance. This is a patient who needs further vasodilation, and hopefully that will improve their cardiac index. Even though it's in the normal range, it's getting towards the lower end of the range. But we need to be careful. Excessive reductions in systemic vascular resistance may be harmful, may be good for the heart, may offload the heart, but it's going to be shunting blood through tissues unnecessarily. So you might end up with the heart doing more work for no gain. And of course, you might be stealing blood from essential organs like the brain and the kidney and just shunting blood through peripheral muscle, which at rest doesn't need that extra blood. I think we've got two approaches to the management of heart failure. We've got the set menu. So the chef decides what you get and how much. And if you don't like it, you just leave it. Or we've got the a la carte menu. So the chef offers you choice and advice and tailored to your requirements. You can change your mind. You can order a second helping if it's good. So this one is the sort of titrate to target dose if possible and no higher. And this is what trialists were supposed to do in clinical trials. But of course, the trialists were also physicians, and I think they often titrated to the physiology. So I think this is often what trialists did. It's rare for